gonna record this because this is insane.
Go ahead. Go ahead.
Wow.
So yeah, that's the beginning. So this is 11 vertebrae of a blue whale spine, right? In the caudal section is the largest of the vertebrae. So 11 of 56, and they're suspended ceiling, right? So they're actually individually suspended, and each vertebrae is suspended so I can show disc height loss.
Wow.
Yeah. So, yeah,
That's
part of the
awesome.
patient education experience that people get when they come into this clinic.
Jerome.
Yes.
So much for your time.
No problem, Rocco. It's your time too, right? Thank you.
You know, I've told that to many people in the past. You are one of the quintessence and trustworthy educators out there.
Whoa, it's quite a hat.
I mean it.
Well, okay. Well, thanks, but that doesn't. I don't know. Just keep on marching forward, right, and towards the truth for patients.
Yes, exactly. And that's why I wanted you on, because through actually your babies, I've and more are going to be in the toolbox about actually creating and educating more patients, and actually ourselves.
Yeah, you know what? That's one thing too that I didn't really understand the value of I created these for patients primarily, right? And I began crafting and trying to come up with something that was more realistic for patient engagement, because we didn't have anything dynamic on the market. It was all just static. So it's very difficult to help patients understand, oh, it hurts when I bend forward, doc, right through that segment and it disappears, or then, it comes, or whatever it may be, whatever the clinical presentation is. We had static models. It was like time for something new, I thought. But what it also did was it opened my eyes when I started creating viscoelastic properties to properly scaled annulus, nucleus, even the texture of the nucleus. I worked with surgeons to get their feedback, right? I even worked with anesthesiologists with puncture force feedback with their needles. But when I started to create, I was all about, creating a realistic model. Then it was too stiff, right? It was like, and you couldn't really use it with your hands. And I was like, nope, this is the way it's going to be. But then I realized in order for people to use it, I had to soften the materials up a little bit. And so it's deformable and movable. So
dynamic.
Yeah, and it's dynamic, and it's taught me so much. Like now when I'm just doing an evaluation of a patient, I can see as the facets, as the patient goes into a flexion, for example, and they have a little, oh, it's sore. Oh, what is that? Okay, so now is there shear that's occurring and the facets are a pain generator, right? Is there anterior translation? Now the facets are a pain generator. Okay, well, or is it discogenic, that there's a little fissure in there that's spreading interposed disc herniation, right? Then it disappears. So you know what? It could be a position, a spot on the facet that's got a little bit of a fibrillation. So as they come back, sometimes when they come back, they feel it more because now it's translated further while they're in flexion. And now when they come back, there's more shear translation, and then you can check. So anyways, they have helped me as a practitioner. I didn't really realize that until I started crafting and changing and using different models. Like this is more of a sort of a younger person, because we do have, it's actually, we've got a heterogeneous disc. We got a nucleus and an annulus. Well, we know as time goes on, the lines blur between the nucleus and the annulus, and the stiffness changes, and not always are we going to get this momentum of the nucleus butting up against the annulus, right? And so as I started to craft with different cadaveric specimens I started to see, oh, okay, so that ligament, when you go into extension. So yeah, as a practitioner, it has taught me a whole bunch. And I'm very grateful for that, for the customers that are interested in these models to help me to continue to innovate. And so, yeah.
Where did the idea come from? Because I know you've been in the industry for a long time. Where did the dynamic part of your tools came out, of the models?
Well, it was kind of simultaneous. I sold a practice and I was moving primarily for my family. And I was in a clinic and I didn't have any patients. I thought, I developed a practice in a satellite clinic. It was very successful where I was. And then I was like, okay, no, it's not about you, Jerome. No, it's time to move. So I then moved to a different location, I basically about 2.5 hours away. And, and I thought, okay, yeah, got skills and, I'm ready to go. And then it was like, wait, nobody knows anything about me and I don't have anything to do. And, oh no, I got mouths to feed. I've got kids to put in dance and I've got food to put on. I'm like, oh, what did I do? Right. So then with my schedule was empty. And it's all about, I've seen several posts about, you put out incredible messages, Rocco, on your story. It's about, they're motivational, right? It's about all sorts. Like, I don't even know where to start. You've been, but it's about taking action. I've seen many of them through you, right? It's about taking action. You sit there at idle and you dream about these things. It's about simply just taking action. So I just did stuff to build a better model because I was like, okay, when patients come in, and everybody wants to be the best. So I thought, you know what, when people come in to see me, they are going to get the best patient education they have ever gotten. And that's what's going to set me apart in this town to generate business. And then at the same time, I was doing, I had these research questions that were kind of bubbling up inside of me. So I basically initiated research using upright MRI. And then on the other front, I kind of started to develop a better patient education. I didn't even expect this dynamic disc designs to do what it did. That was just kind of how everybody was kind of like, yeah, it just evolved naturally. It was just for my own personal use. So, and it's been, I don't know how long now, 12, 13, I don't know, it could be 14 years. I've lost track now.
I know it's actually, as it's mine, it's a lot of other great practitioners out there. One of their actually tools that they use. I've seen them in many podcasts. I think Stuart McGill uses it a lot. I use it a lot in my clinic. Now my clinicians, the fellow clinicians use it as well. Because what I wanted you to do today is educate me.
Okay.
So I was thinking, just we can go through actually, I've got some questions as well, and I know you have some questions as well, but I know you've got the answers for most of them. If we can go through actually the vertebral bodies of how, because this is actually the closest as we can have regarding an actual model. And if we can transition to an older patient, and then explain the differences in flexion extension, because we've got a lot of people out there that posture doesn't play a role, flexion doesn't play a role, extension doesn't play a role. So I know we're cringing a bit, but if we can go through the nitty-gritty of everything, I would really appreciate it.
Well, it all depends. You know that, Rocco, right?
It does.
Everybody brings in their own little package of anatomy, and you have to try to unpack it for that patient if it's pertinent, right? So you have a question?
It's really interesting that you said that. My first year in chiropractic college, the anatomy, Dr. Vijay Pabathi came out and said, guys, I know you've got a Renas anatomy book in front of you. It's just a book. When we're going to do cadaver labs, that's the truth. So yes, keep the anatomical points, keep the names, but it doesn't have to do anything with reality.
You know those variance bars that you see when people do stats, right? That should be hooked onto each anatomical region that you are investigating. There's variance. So speaking of that, so does left equal right? You know, let's talk about, so these are all casted from real cadaveric specimens. You know, and I choose them very carefully because I'm like, okay, you know, what is important and what do I see clinically? If you look, the facets here, these inferior facets here there's tropism right out of the gates.
Yep.
Right. So we have tropism. So when somebody's bending laterally and you're kind of looking, okay, you know, is the person bend left equal to right? And there's just something that I want to fix. Keep in mind that their underlying structures are, I find zero symmetry in the spine. Is left never equals right at each level. Yeah. So let's just start with that one, right?
Yeah.
So you have to watch the motions and so anyway, so these, so of course, here's an L5, an L4, right? And this one, this disc has been created with a circumferential disc bulge, so extending beyond the vertebral borders, right? Taking up space in the spinal canal, right? Right, and so, and on the left side, we've got a protrusion. So people throw, you know, I got a disc herniation. I got a disc herniation. Don't forget the subclassifications of disc herniations.
Yes.
Right. And some of them do better than others. Is it an extrusion? Is it a large extrusion? Is there an opportunity, right? Is there an opportunity for this large extrusion to resorb? Yeah. Right. The larger the extrusion, the better chances of resorption. So from an empowerment standpoint, you can just show a patient, you see, this is what you have on MRI. But guess what? You could show them there's a great chance that this is going to, yeah. So you have to, you know, we're as clinicians, we're chasing often diagnosis, right? But you've got to think about the framework around what the patient wants to see hope, wants to see what the future brings, right? So it's almost more important to show the resorption, right? Or on the contralateral side, we have a protrusion where it's contained, the nucleus is contained, a little trickier. So you can explain these things that, you know what, you have a protrusion, it's a little bit more challenging. It may take more time for this to settle down, but this is what you got to do. You don't have one of these, but you've got one of these. Oh, so it's, so now we've got a model to help kind of explain some of these MRI findings, right? Instead of just generic, and they, you know, of course, all patients go home and start Dr. Googling it, right? Right, just to kind of see what you said, whether it matches up with Dr. Google, and then they go to YouTube and find their own exercises, and you know how it goes, right? So this is the professional LXH model. You can see it was my first model ever created. I created a clear lens so we can see. At the time I was doing, I actually sat beside Fremont, AJ Fremont, who did that study where the outer third of the disc is innervated. That was in 1999, and I slid up beside him and I said, "Hey, what do you think of my modeling?" You know, I was at a conference. You probably, I don't know what he thought of me, but I dropped this on his lap and I showed him the innervation on the outer third, and he's like, "Oh, well, you've done well, son." I was son back then.
Because that was a breakthrough back then. Because when we have people with pain, we saw the interventions, the nerve interventions in the disc, which people didn't think that there were any. That's
right. Yeah, exactly. So I wanted to showcase that. So in the case of when someone bends forward and they have, oh, it's sore, and you suspect discogenic pain, right? You can show them there are the nerves on the outer third of the annulus. You can talk about neo-innervation, new nerves that grow into the inner 2/3. You know, and I've got, you know, vascular elements in the vertebral
Yeah.
body, and end plate pores and end plate fracture in there. If you suspect somebody with the heel drop test, there's a bit of a end plate disruption. And just 3 years ago now, I re-engineered the disc to have this circumferential disc bulge with, there's an end plate. There is the hyaline end plate right here, right? So there's a bony end plate and there's a soft end plate, and that's the cartilaginous end plate that I've integrated right into the annulus here. So in the cases of, comes up on end, like a Schmorl's node or what have you, and you suspect it's sensitive and sore, well, you can show them now, right, with the realistic model here, right? And also what I've done with the facets, before it was paint and they would rub off a little bit, which I think you have one of the previous versions, but what I've done now is I've created hyaline cartilage, simulated hyaline cartilage. So there's a viscoelastic component on the facet joint, so they can understand, how the facets will actually load, and there's an element of shock absorption with the hyaline cartilage, right? And there's a little fibrillation or little injury I've put to the facet too. So if you want to talk about the earlier mechanisms, because it's younger, earlier mechanisms of advancing, right, degenerative arthritis. So I'm all about prevention, and we can teach these young kids early about how to sort of mitigate disc height loss over time, and how to prevent these injuries, these kind of repetitive injury strains. And I think we could do better in trying to the end. It's all about the end game. Part of it's about the end game, right? We want to lessen the chances of developing lumbar spinal stenosis. That's one of my goals, right? Is to try to see if we can, over time, learn and see if we can slow down the disc height process by understanding more about the motion segment. Cauda equina, now we've got rootlets. This is actually to scale. Yeah. All right, so you can see that I've put the cauda or the dura mater on there. So so this is, and you can see here that we still have the lordotic curve.
Yep.
So we've got 10 mils on the back, 12 mils on the front, and we do still have that lordosis. So under load, the nucleus stays, or it's contained more anteriorly. As soon as you get into the state where the end plates are more parallel, if you think about the nucleus, now the nucleus will begin to shift posteriorly and start pushing up against the annular fibers. The annular fibers will come taut a little bit, right? And the nucleus just starts to push up, right? If the annular fibers are good and have great integrity and there's no fissures in there, well, guess what? Flexion is going to be fine, right? But if you've got a tiny little fissure in there, right, and it's progressive, we just saw another paper come out, there's a progressive nature, it kind of just starts to open and can fissure a little bit, fissure. And if you go into flexion, it's just simple mechanics. If you've got a sandwich and you've got a bunch of ketchup in there, you squeeze it from the front, it's going on your pants, right? And then if you see it from the back, it's not, mechanics matters, but it really depends on the integrity of what's going on inside the disc. Are we trying to slow down that nuclear momentum, right? The nucleus, think of like a big sloshing element. That's if there's nucleus. Is it going to boom? Does it come up quickly against that annulus, right? Or is there a slow where the forces are dissipated, right? So
is it a brick wall or is it a sieve? That's why I usually say. And
right?
that's why neutral spine, especially after an injury, plays a massive role. So we can actually let it heal.
Yeah, and I'd use the word, everyone gets excited about neutral because it's like something in a gearbox where it's like, that is the precise spot. But keep in mind, it's relative neutral.
Yeah.
Right? It's relative neutral. Right? So I think people get hung up with neutral like it's in a car, a transmission, or you can't find.
I wish it was.
Yeah, no, it would be good. It would be good. You're right. It'd be nice. You just kind of, put it in neutral.
Regarding the flexion and extension, what you actually said now, we've seen numerous studies about what happens with flexion under load.
Mhm.
And usually what I chat to patients or, some of the athletes, which are patients, is the change between this when we have load and this by using the pelvis. And
Yeah.
actually, you've seen it numerous times. Can we go through it? Because everything plays a role. We need to dissect everything and see exactly what actually causing those micro injuries or that bulging disc or that herniated disc, right?
Well, I don't know if we can be exact, but we can do our best, right?
Mhm.
Right. So you want to talk, what would you like me, do you want me to talk about the hip hinge as it relates to the intervertebral
Yes.
disc?
Yes, please.
Okay. I got to go get my femur. I'll be right back. A real one.
Lots of bones. That looks awesome, actually. Wow.
It's a biggie.
That's a big one.
Right. Where are we here? Right. So
Okay.
There's a femoral head, and look at that. What does it look like? It's
Wow.
like a bit of a ball, right?
Yeah.
It's a ball. Right? Could be a billiard ball. So what do you think the function of that thing is?
Yep.
It's, right? And there's the associated acetabulum.
Socket.
Right? And then you've got that. What do you think? Right? Like what totally different design, right? Right? So different purpose. So when it comes to, so if somebody has symptoms and they bend forward and they're like, ooh, I can kind of feel it through this region, very likely what they're experiencing, likely, you get all sorts of comments, right?
Oh,
No, it's not.
yeah.
No, it's not. It's tight hip flexors, or the glutes
Psoas.
aren't working, or psoas, or right. Okay. From a spinal perspective, right? You can see here, this one's created with more viscoelastic properties. So this one will fold, right? That bends, right? This one's been created with a reduced disc height and stiffer, right? 5-1. Right, stiffer. So we've got, right? So every time they bend, it's like, ooh, why is it sore? Ooh. So if you continue to create these micro
Injuries.
Well, people don't like the word injury, but
Okay.
ouchies.
Ouchies.
So important that you use, I'm talking to you as a clinician right now, right? So when you're talking to patients, you use different words. Right? It's important to distinguish the two, right? So with the hip, if you bend about your hip, you're going to be minimizing those micro movements of where that pain trigger likely coming from, to give this an opportunity to heal.
Yep.
Right? So this versus that. Right? And you teach them hip hinge. Then I look at it, and this is how I describe it to patients. And it doesn't create like fear avoidance, because you're teaching them the mechanism of
to avoid further injury or further ouchies, or actually.
And remember, you have to, exactly. You got to frame it within a certain amount of time. I often say, when you break a bone, what does the doctor do? Right? Put a cast on it, right? For a certain period of time, and they tell you 4 to 6 weeks your cast is, 4 to 6 weeks the cast is coming off. Well, that's great. You have to frame it similarly, right?
Exactly. Yeah.
So if they have problems in their back, you have to tell them, what we want to do is we want to start sharing the load. We want to put the load into your hip, because look at the design. It's designed to do this for you, So why don't you start using your hip a little bit more and give your back an opportunity to heal? And then they're like, oh, okay. So there's a certain time frame. They understand, they see the mechanism, right? Here's another model that I create. This one's, you can see here, moves more.
Oh, we're gonna have a really nice conversation about instability as well.
Right. So that one moves more. So I bring this one out and say, hey, what you've got, and you know when I pushed on your back, right? Anyways, so I use this model to help to kind of get them oriented and get them moving through their hips. And they're like, I don't know how many people told me, oh my gosh, you fixed my back pain. And it's like, no, you fixed your back pain. Oh,
I just guided you how.
I just got to see it. Let's talk about that right now, right? Paper just published. Okay. Spine Journal. Clinical study just last week. What does the patient want with back pain? Okay. What do they want? Okay, this was a study where they asked patients to rate each of the following with regard to their importance to you. Okay, and this is, I don't know if you have that graph available.
Let me just put it on. Let me know if does this come up?
Yeah, okay, so if you look here, number one, importance, improvement in pain. Okay, well, that's a no-brainer, but you know, but some people forget that actually. Second one, improvement in function. And what's right up there, almost just as important, is an explanation.
But what is causing the pain?
An explanation, a logical explanation of what is causing the pain. These researchers said patients did not place as much importance on diagnostic tests, which we are always at our forefront. We're always thinking diagnostics, but we've got to switch and remember that. So they didn't put as much importance on diagnostic tests, medications, and surgery as physicians assumed. Physicians understand that back pain patients want improvement in both pain and function, but they underestimate the importance of an explanation for their pain.
It was really interesting when you sent me that paper. It actually, because sometimes it's really important what you actually said. It's about dead words, as I say. Oh, you've got this or you've got that, and it sounds like a death sentence sometimes. And you don't actually explain, because words do matter. But
of course,
and that's what I found with your models, because actually you made my life and my patient's life easier, because I could actually explain with something they can visually touch and see, rather than just putting some words.
Yeah, exactly.
And the shocking part was surgery that not important, which I like, regarding the graph. Yeah.
So it's you know, and I was thrilled because I can see how patients engage, and they just are so thrilled. I had a patient last week, and she's been suffering with spinal stenosis for probably 6 years, been, you know, this clinician. And it took me all of approximately, I would say, 2 minutes to see her symptoms and then explain it with the model. And she was just dumbfounded. She's like, I totally understand my symptoms, and I totally understand now what I need to do.
So can you go through, actually, let me just take that out of the way. Can you actually explain spinal stenosis to everybody that's listening with your brilliant model, and then I'd love to ask you a question regarding the disc height that we're gonna ask you later.
Sure. Yeah, for sure. So, what's classic for spinal stenosis? What is classic, right? Classic is that they can walk a certain distance, and then they have to sit down,
Symptoms, yeah.
right? And their symptoms abate. So what is that, right? So, so what I did, I brought out the model and I said, okay, first of all, she had, was it an X-ray or she had a CT? I don't remember now which it was, but I showed her the model, showed her a normal, okay? I pulled out the cauda equina out of
Normal.
Well, you can use this as a normal because it's got good disc height.
Mm-hmm.
And I said, do you see the canal? I said, look how, see the space of the canal? You see how big it is, right? You got room in there. That's where these guys go. Right? These are the nerves. They go in there. You see the spacing? Now yours is more like this.
Go down now.
And yeah, well, if you look down the canal, exactly, you could do a side-by-side comparison, exactly, right? And you can see that the thickened ligamentum flavum approximates the spinal canal, right? And so and then what I wanted to show her is when she walks, right, there is overall compression. It's stiffer on purpose, the model, but when you take it into extension, the spinal canal will actually narrow.
Yeah.
And it's subtle, but guess what? From a vascular standpoint, around the cauda equina, it's like it's kind of getting choked off, right? Vascular elements are just getting choked off. So when you take this model into flexion, the AP diameter increases. Yeah.
Actually, what you actually do is you compress because of the limited space.
That's right.
The spinal cord.
Yeah, like that, right?
Which it doesn't like that.
No, nobody likes to get choked.
No.
No, especially the rootlets. So, so then okay, well, what is this, right? So you think about the patient, they're like, well, there's a bone, weird looking thing. I don't know, lumpy, they don't know, this is like strange. So then I wanted to give them an experience. So I said, okay, here's a pen. Let's put it up into the spinal canal. And we know that nerves move. Shock lock, all right? Shock locks work. They move, right? They move, right? Up and down a little bit, everything moves. So I said, okay, well, what I want you to do is move this up and down. So she's holding on to this. And I say, move it up and down like you're walking. It just goes up and down, maybe a couple millimeters up and down. Then what I do is I grab the spinous processes and I go, okay, well, as you walk, the disc height goes down, and all of a sudden she's like stiff, right? She feels the friction. She actually feels the tightness, which correlates to her leg pain. And then I said, okay, so now what do you typically do when you get symptomatic? She says, well, I sit. So then I go into flexion, and all of a sudden it frees up. And she just goes, wow. Really? Nobody's ever showed me that before. I know, because there's never been a model like to actually show it. So how is anybody going to show it without a model? You could talk about it. So I gave her an experience, and now she's just like, okay,
I totally get it.
and I'm coming in. What do I need to do? And you don't have to. Now she understands which exercises. Like she goes, so do you think that maybe if I do, this exercise? I said, what do you think? Well, yeah, you're right. That is a good one. So I go, how about this one? And she goes, no, that's not a good one for me, right? All of a sudden she's
in control.
the doctor. She's the one. She's in control. She understands her spine. And it's important to not project that this is totally fixable, because there's been years of disc height loss, and now it's about being manageable. And that she respected that too, right? You can come in saying, you know, I got the fix, I'm going to fix you, you know, I'm the next best thing, coming in with on my white horse, and I'm going to make it all better. But you have to create realistic framework for these patients. They respect the truth. They
Yes.
absolutely wholeheartedly respect the truth, right? And you tell them about, you know, well, this could happen down the road, and we're going to see how it goes, and you know, let's hope that we can create enough room for the nerves, because I think we can. You know, you don't have radicular leg symptoms all the time, so that's positive. That means there's enough room there. So let's preserve what you have and see how much life we can get off these tires that you have, you know? So, and, you know, and this one also I've created, so that's central.
Yeah, that's what I wanted to.
Yeah.
Yeah, that's what I wanted to ask you about, the actual narrowness, because we had a chat about regarding hypertrophy or density of the ligamentum flavum that actually you have. And then you can see actually the difference between one and the other, where the nerves actually come out.
Yeah, exactly. Yeah. So with, I was even just observing yesterday how interesting this is. When look at the size, let's just talk about just size of facet, okay, versus this. Look how much longer these are. Yeah, no one talks about long facets, do they? But this is a story over progressive disc height loss slowly over time, and the facets taking a bit of a, right, and hypertrophy developing. And in this case, this hypertrophy went anterior and superior and projected into the IVF.
Yeah.
So now we have a narrowing of that IVF. So in extension, it actually closes. And in flexion, it actually opens. So, you know, I usually use this, you know, for those stenosis patients to start with, and then I can get a little bit more granular and put the cauda equina right in there, or sorry, yeah, the cauda equina, and then the nerve root comes out, and you can kind of show them what's happening if it's only purely lateral, right? But and as the disc height goes down, discs need to, like, there's mass there. So where does it's got to go somewhere. So that's where these bulging elements kind of come from. Well, there's debate over the ligamentum flavum, whether it's hypertrophied or thickened, or you know, there's other sort of spins on it. But if you just think about it, if it has a certain volume and it compresses, it's got to go somewhere.
Yeah.
So and we've seen this with extension MRI, where the ligamentum buckles into the spinal canal, right? So so that's what this model also is helpful, right? It can kind of show that that the ligamentum can kind of come into the canal a little bit too.
I really love how you actually show the degeneration of the actual.
Yeah, you can feel it.
Yeah, it's just amazing.
Yeah, and then on this one, on the left side, you can see there's a section that is not so sclerosed. You see how it's progressing? No, up above. Go up one more, up one level. There. No, up a little higher, right at the top. Left, the other side. Yeah, look at that facet surface.
Yeah. Oh,
you see how so that has more sclerosis on the right versus the left. And you can see there's a little pocket still on this facet. Yeah,
there's just a bit here. Yeah.
Yeah, it's still flat there, right? Yeah. So that is very likely, I'm speculating, but I would say that is a non-painful, potentially non-painful, and this could be more of a reactive, painful, inflammatory aspect. You can see that facets can be partitioned. You know, the facet surface, you know, at the superior part can be different than the inferior part. So maybe it's sensitive at the top of the facet surface and not so much at the bottom, because when they go into flexion, there's more shear. Anyways, it's more detail than I think anybody really needs, but it's there, right? These are the sort of things that have helped me understand my patients better, and help kind of explain to them when they're kind of curious about, you know, why does it hurt?
But also this, for me, and tell me if I'm wrong, because of that antalgic gait, you put abnormal loads because of the actually, let's say, misalignment. And, you know, you see people coming in on antalgic gait like this, and then it's like, how long have you been there? You know, and they're like years and years. So the stress of the joint on the specific segment can actually create that, that actually tropism, no?
No, I don't think tropism. Tropism is something that doesn't develop, right? Yeah, for sure. There's an explanation. This one actually, I think this person had a rotational issue too, right? Right, and it flares out over this way. So yeah, very likely. I don't know the story, right? I have to
100%.
think about, right? But you're definitely, something was definitely not symmetrical with this individual, right?
Yeah.
So,
and also you talked about disc height, and I usually talk to my patients. I'm like, oh, look, I'm just gonna have go have like a microdiscectomy just so I can relieve my pain. I'm like, the surgery, like Stu says that is like, okay, I just touched you, you just had a surgery, can you act like it? And I always say, look, if you have a microdiscectomy, that means that you're gonna lose this, and you're going to end up with this, which is going to lead to a sequelae of other symptoms, other problems. What do you think on that?
Well, it depends.
Yeah, of course. Yeah.
You know what I mean? Like some cases, some people actually need it, right? And they, you know, they've tried and explored all avenues, and it's for some reason there isn't a granulation tissue that's developed, and now that nucleus does not want to resorb. You know, it's out based on somebody's anatomy. It's abutting up against the nerve root. You've tried everything. You've done everything, and that, you know, that you can think of, and guess what?
Then, yeah, it's
right.
Yeah, 100% of that.
Right. So I've seen cases like that. Right. There's sometimes we just it's almost I'd hate to, you know, surgery is warranted. But for the majority of cases, it's not, because you can find ways to, you got to find that window of opportunity and just build from it, right? Just open it up. Even if the window is like a little porthole, find the porthole and progress, right? And build around it. Yeah, no, for sure, Rocco. Absolutely. You know, and, you know, it depends on each case, right?
Yes, every that's why I was writing actually an article for our clinic, and I was saying that you know, every patient or every degree is a new start, because there's so many things you actually learn, because you know, mastery and being like a master in what you do is doing actually everything as good as you can, and every day you learn more. And every patient, you know, I'm learning now from you, learning from that patient that come in, and you see things that you cannot take anything for granted, if that makes sense. And you need to, what we take for granted that we know is we need to re-educate us of how we're going to educate our patients, and then get to the point that everybody's a new patient, everything is a new case.
Yep.
And
yeah, you're right. No, you got to start fresh. You have to clear your cookies from
yes.
your, right? You got to clear your cookies.
Yes, that's excellent. Yeah,
right?
Exactly. Yeah.
Right. You got to just keep it fresh. Try, you know, use your biases, but don't lead with your biases.
Yeah, exactly. That's an excellent point. I saw a really nice paper. You shared another really nice paper regarding segmental instability, or if we can say that. There are a lot of people out there saying that that doesn't exist. First of all, if we can explain what spine instability is, and then what do you think about it?
Doesn't exist?
I've heard that numerous times. Believe me. Have you heard it?
That doesn't make any sense to me. Well, why,
Thank you.
if you get you get a car accident, things are wobbling around, flexion extension films, and, it exists. It's a matter of degree. And when do you intervene? And when do you need to intervene? It's not that so it's illogical to say it doesn't exist. But is it quoted as being more common than it is? Maybe some people are, talking about, I think we have to watch our language and use,
Exactly.
hypermobility versus instability. Instability is typically used more like regarding a clinical state where there needs to be some surgical intervention. Sometimes, but
Mhm.
it's a language
It's
we
there.
use.
Yeah.
Yeah, and we've got micro movements. There's not all discs are equal, right? Some of them move a little bit more, some of them move a little bit less. Sometimes it doesn't matter to the
Sometimes it
patient.
does.
Sometimes it does. It's your job as a clinician to figure it
Exactly.
out. It's what did you want me to talk about?
So instability, you've got an amazing model there. Can we go through it?
Yeah. So, on here we are. Here's a nice little X-ray. So everything looks pretty good. All right, good disc heights. All right. That looks pretty good. No, not seeing any instability. Not seeing it. How do you need to kind of move tissues in order to see if things are moving wrong. And I love the work, the Breens, and they, their motion sharing research, like that is just so. This disc here has been created with half the stiffness. Right?
Mhm.
So when you bend the model, you can see that this disc moves a little bit more.
Yep.
Right? So is this an instability model or is this a hypermobility model? It really depends on how much force and load I put into it, right? So is this spot a little wiggly compared to the other segments? Yeah.
Yes.
Right? Do the facets touch a little bit more at that one particular segment?
Yes.
Yeah. So it's moving more than this. And if this is a pain generator, what I typically do when I suspect that, a hypermobile disc because it's lost a little bit, it's like what Stuart McGill talks about regarding losing a little bit of air in your tire.
Yeah.
Right? What does the tire do? It kind of, right? Kind of a little bit, right? Kind of go around a corner. Whoa, right?
Plus it
So
wears off
discs,
faster.
right? Wears out faster. There we go. Good one. Didn't think of that one. Exactly. You want optimal pressure, don't you? You don't want it hyperinflated either, do you?
No.
Doesn't. So that's, these astronauts, right? When they go to lay down in this hyperhydration, right? And they have to kind of get back to that neutral state or neutral-like kind of pressure. Anyways, where was I going with that again?
We're saying about the lost height that, like Stu says, regarding the loss of.
So you lose a little pressure and it starts to move a little bit more, right? So when I suspect this, I put them, during my evaluation, and it's, often we end up, okay, get on my table, right? So they get on the table, right? And they're getting all comfortable and stuff, and they're kind of, and you think, okay, it's time to palpate. I don't even touch them. I get them to lay down, and I say, how's that feel? Right? Because we know that there is going to be shear translation and the disc press. There's been load that's come off the whole system. And we know that some patients can't even relax their back because it's sore as things start to shear and translate down, right?
And that's an excellent point because it doesn't go like this when you lie down. It's slowly transitions.
So it goes like that, right?
Yeah.
So I say, how does your back feel? and they say, oh, it feels good. I'm like, okay, all right. So then I go and investigate. But if somebody says, oh, I can feel it. I can feel it. Well, what are you feeling? Right? You know, I'm thinking, right? And there's likely an unstable segment in there, or hypermobile segment, or something moving too much, or something's not moving enough. Something's right when you just, so we don't even, I think that's an important part of an assessment that we don't even really pay too close attention to. So when they lay on their stomach, they go, oh yeah, it's sore. I said, where do you feel that? Right? So then they kind of point to the general region, right? And sometimes I'm like off. They're like, oh, I can feel it. Oh, okay, that's different. It's up thoracic spine. I was suspecting it was lumbar, but or wherever it may be, right? Then it starts to guide your investigation. And what I'll do is I will push posterior to anterior, simple, just simple stuff. Keep it really simple. I just go push here. How's that feel? Oh, it feels fine, right? Oh, right. Oh, I could feel a little bit. Oh, okay. Where do you feel that? Oh, I feel that kind of down in my buttock region. Oh, okay. Try to use the same force. Oh, yeah, no, that's, oh, I can feel that. Oh, you can really feel that? Yeah. Oh, yeah, that's sore. Okay, right. You take a note here, right? You're on L3 spinous. Go to L4, and all of a sudden it kind of, oh, no, that's not a sore. L5, no, that's not sore. Then you push on the sacrum. No, okay. So then you go, and I go back, and it's like, okay, oh, yeah, and then, ooh, right? And then, oh, so there's an apex of sensitivity in this particular location, right?
Yeah, because
That's
it's
kind of
one
how.
single synchronous system, right? Like if one
Yeah. This will take up slack, like that'll take up slack, and then that will move eventually, right? So my P to A evaluation is so, I've gone even so far to use I got to go get something. I'll be right back. So I use a device that it took me about 3 years to develop this. And now there's a dissertation study using it, but this is called a pain meter. So this is a device that the patient holds in their hand. And while I am evaluating, instead of them telling me, ooh and ah, exactly, Rocco, what they do is they gently squeeze it. It's like, oh, okay. Oh, yeah, that's okay. That's sore right there. Oh, and then all of a sudden, sometimes on the recoil, you let it go and it's like, oh, yeah, that really hurt. So this is a device. Yeah, so it gives me a better engagement, feedback. And sometimes, I don't go in there too zealously pushing things without, some people are very stoic, right? And their right leg is going numb and they're not even telling you, right? Right. And some people are overreactive. So this kind of gets a good little framework around, and this is all saved to the chart and export so that I can compare visits, right? So I can, come back next time and evaluate and go, okay, is that L3 segment as sore? Oh no. Okay, they're doing their hip hinges. They're kind of doing that kind of, giving this an opportunity to heal. But anyways, little device that I wanted to develop. And patients feel more, they feel more listened to as well. Yeah, right? It's a patient-centered device, right? So
yeah. In the part that you feel that a patient is unstable, as you said, at L3, L4, right?
Yeah.
And then you tell them to have some mechanical tension, and that is still there. Because without mechanical tension, you actually keep a more stable segment.
Yeah. Yeah.
And then you do the same thing, and then you get pain back again. People say, oh, there could be something more sinister. And I go back, I was like, have you actually educated your patient of actually what Stu says really, really, really nicely about the dimmer, about how much pressure you're putting overdoing it? And I remember most of the patients, when we were doing testing, I remember everybody was like, oh, I've got so much pain. And then when you say, okay, dim it down, don't go through the roof like a proper Valsava, just add a bit more pressure and tell me how that feels. What would be your diagnosis is if in case they had enough pressure, let's say not over the board, and they still have had pain?
So what do you mean by pressure? What do you mean by?
So let's say they brace, they keep that tension. So this,
Oh, you're talking about just the bracing, abdominal
just the
bracing?
bracing, yeah.
Oh, yeah,
And
okay.
then you go segmentally and you go in the specific segment, you test it,
Yeah.
and
Yeah.
they get pain again.
Yeah. So are they standing or are they prone?
They're prone.
Well, I don't think bracing can take away all the shear, especially when you do P to A. I don't think you can rule out instability still.
Thank you.
But you're saying there's no change of the pain? The pain is still exactly
There's no
the
change
same
because
with the
you will,
exact.
if you brace, you will have a change, and that's the good aspect because you know what you actually can do to actually help the patient. But let's say it's exactly the same thing. Nothing changes.
Yeah, it depends on, like, there's the leg extension where you engage the muscles even more. You have to kind of find out if they're bracing effectively. There's all those elements too, right? And you have to evaluate when they're standing. So, but you're wondering about the differential. Go ahead.
Well, my all this started because I wanted to ask about how the efficiency of testing.
Oh, yeah, nuances, lots of jazz.
Because you said, especially with the press, you said put the same pressure. And that's how actually it gave birth to that question, because we still have testing. And through my talks with a legend that you talk about, Shacklock, regarding testing, and even the SLR, when I have a questions and we go through it with him, it's just different kind of like world. So from your experience testing, tell me about jazz.
Well, Stuart McGill talks about playing jazz, right? You got to get to know, for testing. First of all, right in the very beginning, I talked about variations of anatomy. So testing what? What's your question? Testing, what are we testing?
Like, for example, now we're saying we're testing segmental instability, right?
Oh, yeah. So, you put together, like, for example, there was a paper that just came out that looked at, is there facet joint effusion at that particular location, right? So if you see that, you're thinking, okay, there's a good chance. And if you combine your palpation at that particular location and the bracing alleviates it and the hip hinge alleviates it, and
no brainer.
I don't know, no brainer, but at least you're kind of going down a very solid path.
Okay, yeah.
I think you're going down a reasonable path, right? Especially your outcomes are the big one, right?
No, it's also, sometimes it's really important that the graph we put before about when you're actually explaining what you're looking for, the patient understands more what you're looking for and how things work. Because I've got patients that they don't really like me because athletes mostly, because you're like, the way that your facet joints are angled, this is not something you need to you do, because you can
you're not designed. Yeah.
Yes, you're a 4x4. You want to run like a Ferrari. It's not going to happen. So either you change the way you do it, like high kicks, for example. I've got people like they're a bit older now, and they're like, oh, I've got back pain, but I need to keep training. And we see the movement. As like, man, this is not going to happen. You're not designed for this. It's like, no, I've been doing it for so long. I'm like, as Stu says, you deserve your pain. And then you check somebody else and you see a wider angle, which is much better for him to do whatever he wants. And it's about, yes, educating people, but then, you need to actually tell them what they can and what they cannot do because of their anatomy.
True. I never tell anybody they can't do anything, right? I'll never do that. I'll never actually say, I'll say, this is my investigation. This is what I've revealed.
Yeah.
These are my suggestions. And, I try to just lay the evidence down in front of them and let them make decisions. Right. It depends on each patient. It
Oh
really
yeah.
depends. Some patients need a little bit harder edge,
Some need
kind of
cuddling.
conversation.
Yeah.
Some of them need softer. Some of
It
them,
depends.
you look at them and they cry. Thank God doesn't happen too often with me. But it really depends exactly. But I hear you. Everybody's anatomy is like I was, when I was doing sports way back, I was a horrible long distance speed skater, right? I just couldn't. I was a sprinter, and so I did really well in the sprints, and then did not so great in the long distance, and so that makes me kind of in the middle of the road kind of a guy, right? But then, if I focused on what I was best at, then, I may have not been here, right? But back then it was like, all around kind of experience. So yeah, you've got to harness your strengths, right? And if you could pull that out in evaluation and based on someone's anatomy, that's pretty awesome, Rocco, because I'm still learning, about who's best to do what, because I think the waters can be a bit they're not as clear cut. I know McGill has got so much more knowledge than me, and he's seen so many more of those high performance athletes. So and I just so respect that, somebody that can, I know Stu's, that's why I developed the Limacon disc in here, right? Because it was based on his low back disorders book and his kind of talk about, how the protrusion will occur more so, right, with this Limacon, because it kind of, it's like funneling the nucleus, right?
Yeah.
It funnels the nucleus as opposed to ovoid.
Yeah.
Right. So, I continue to learn, right?
Don't we all, right? That's a journey we actually started and picked. As a practitioner, which is like, say, if you had the toolbox, what is what's the toolbox? What does it have in it to be let's say, a brilliant practitioner?
Be the patient. You have to be the patient, right? I don't know if that's really in a toolbox. But that should be a philosophy going in. You should always be the patient. So are you talking about specifically about the models, which is, or are you talking about just general?
General, and then how we can add, like, we starting as being a patient, as you said, don't forget that. And then we need to start from somewhere to end up here, right?
Yeah.
So if you would map down to a student, a chiropractor, a new chiropractor, what the advice would be?
Wow, that's advice. Just be curious, be considerate, be truthful, and know your strengths, even though you may not think you have any when you're starting out. You maybe got one, you got two, you got three. Build on it, and it'll just get bigger and bigger and bigger, right? And then always understand your failures, dissect your failures. You have to. Don't go, oh boy, I'm just going to kind of ignore that and I'm out of here, right? You don't do that. It's more, and when we go to these conferences, everybody talks about, yeah, I fixed this and I fixed that. And you know what? Oh yeah, I'm really good at that. Well, guess what? I'm more interested in somebody that comes up to me. You know what? I had a case that really I failed at, and it's bugging me, and I'm trying to figure out why.
Yeah. And
to me, that's where you build. That is exactly where you build. And the great thing is when you're a student, you're just starting out, guess what? You have more failures. So there's more opportunity to learn, So don't shy away from the failures. Attack them, follow up with them, learn them, right? And try to find solutions for them, because guess what? That's your toolbox.
Wow. I'm reading a book by Robert Greene, and actually about mastery, and he actually says about that, because that's a hard pill to swallow. And he always says that, you get, that's brilliant what you actually said. And I'm actually through that. I've got a couple of patients now, which actually are troubling me. And I'm talking to the clinician who owns a clinic, and he loves it. He loves to see the way that you think. And he's like, okay, figure it out. We'll figure it out. Don't worry. Accept that you're going to fail, and you're going to fail again. You're going to fail again. And that's how you're actually going to be better. Because if you only have wins, if a loss comes out, that can destroy you. So embrace the losses, embrace the failures, accept them, and, and accept that you're going to fail, because you will.
Yeah. And guess what? Share it with your patients.
Yes.
Often we are embarrassed, but you're human, and they will appreciate that you are trying.
Yes. So important. Wow. Yes. I'm dying to ask you what's back there, and if you can actually show me the models, please.
Back where?
I can see I can see up on your left a lot of models.
Oh, this. Oh, yeah. Okay. So here's the clinic, right? So when people come in, there's I don't know if you can see that, but that's
Nice.
Dynamic Chiropractic Clinic. So when they come in, oh, what's this? All right. So I've got them all labeled.
Nice.
Right. And displayed. There's a knee that I've developed here recently. That one has, there's a bronze model. It's a brochure. So, and that's adjacent. The other thing that I just wanted to kind of talk about just quickly is I think that scale is important.
Oh, yes.
I think the aspect of, I know I'm digressing here, but I wanted just to point that out before we stop here. But scale is cervical spine.
Oh, yes.
Lumbar spine. Right. So,
yeah.
Do you use the same forces here as a practitioner with this?
Excellent
People
point.
have told people, right? So be mindful of your forces. Look at the size of the disc differences, right?
Yes.
Does it matter? I don't know, but for me, I think it does, right?
It does.
I pay attention
should
to
be.
that, right? And this is from the same specimen, so that's from the same human, right? There's C5-6, there's L4-5, right? This has got the anterior longitudinal ligament, PLL, and a bunch of other cool stuff, right? Ligamentum flavum. But helping patients understand that this big
10-pound
ball
ball
here, yeah, sits on discs that are that big. I've had, people have come up to my booth and said, can you scale that up, and I want you to scale it up to, why don't you scale it up? And this is for my own use, but I scaled this up once, this is actually,
oh, wow,
four times, right? Upper cervical. And I'm like, no, I'm not going to scale this up for people. This is, I did this just a one-off, and for a particular doctor, he was saying, do one of these. So I did. Anyways, but helping patients understand just scale is important, right? When you put this in their hands and you palpate their neck and you rub your finger over the facet joint, for example, or if you rotate and, so that's why I refuse to scale up my models, so we can get a proper scale with the tissues that we're working with.
And closer to the real thing, as close as we can.
Yep.
What's next? What are the plans? Any new models coming out? What's your...
what's next? Let's see what's next.
There's no way you're
not...
the
pain me. This is fun. I hope to, get this out there so people could start to pay real close attention to
feedback,
to what's going on in there. Yeah, for feedback, and so that'll be fun. I developed a new chair, which has been just been published in the Journal of Ergonomics. It's an off-loading chair that actually slowed compression in the spine considerably. So
Wow.
that's fun. Getting it to market is the next phase, and the engineer is working on it right now. So you're going to probably see something. It's unique and different, but it's I think it's going to help a lot of people on the planet.
Awesome.
Yeah.
We find everything at Dynamic Disc Designs, and I always love the posts you make, and actually you explaining everything through the model. So I'm just going to put also the website and your videos underneath the feed as well. And I'm looking forward to seeing you in vivo soon when all this craziness comes down.
Yeah,
and
I think we're getting there.
Hopefully soon. And I really appreciate your time and the help you gave me in trying to make me a better practitioner.
Hey, we're all learning together, right, Rocco?
Yes, we are.
All right, so have a good one.
You too. Thank you for your time.